series. Today's presentation is entitled Redesigning Care Management, presented by Michael Matthews, CEO of inHealth. Michael is joined by Russell Olson, Vice President of Innovation at Untitled. Before we begin, I would like to review a few housekeeping items. Next slide, please. First, you have a control panel on the right-hand side of your screen. You can minimize and expand this panel by clicking on the red arrow in the upper left corner. Secondly, you can submit questions using the chat panel located near the bottom of the control panel. We'll take time to answer any of your questions during the question and answer period of the call. If your question was not answered, we'll do our best to respond to you individually after the event. And finally, at the end of the webinar, please let us know what you think of this presentation by completing a short survey. And as always, we appreciate everybody's feedback. Additionally, we will send out a copy of the presentation and a link to the recording within 24 hours after the webcast. Be sure to check your emails for any follow-up information. At this time, I'd like to turn it over to Russell Olson. Russell, you may begin the webcast.
Great. Thank you, Renee. And we're really excited about the webinar today. So care management is the linchpin to value-based care. And as we see responsibility shifting from traditional care management to a provider-centric model, there's an opportunity for redesign. Maybe a better statement is that we have an opportunity before us to design care management. Steve Jobs said, in most people's vocabularies, design is a veneer. It's interior decorating, it's the fabric of the curtains or the sofa, but to me, nothing could be further from the meaning of design. Design is the fundamental soul of a human-made creation that ends up expressing itself in successive layers of outer layers of the product. So today, Michael and I will talk about these successive layers of design. And so we've asked Michael Matthews, CEO of inHealth, to join us in the presentation to share his layers of successive design for care management. So Mr. Matthews has served in the healthcare industry for over 35 years, leading a variety of different organizations dedicated to improvements in the effectiveness and efficiency of healthcare delivery. His leadership positions in Health Information Exchange included serving as the Chief Executive for Med Virginia and Connect Virginia, as well as serving as President and Chair of the Board of Directors of Healthy Way. Accomplishments include being one of the first HIEs to connect to the nationwide Health Information Network and one of the first HIEs to connect to the Veterans Health Administration and Department of Defense health record systems. His efforts have been recognized by such organizations as eHealth Initiative, Information Week, and Becker's Hospital Review. He's also served on the Commonwealth of Virginia as Senior Advisor to the Governor's Office of Health IT as Commissioner on Health IT Commission. So with that being said, Michael, welcome to the presentation, and I'll go ahead and hand it off to you.
Thank you, Russell, and good day, everyone. It's a pleasure to be here with all of you. As you can tell from that painfully long introduction, I've been at this for a while, or as I told a group of colleagues recently, this is my first rodeo, but it's been a really long rodeo. The things that we're talking about today have been around in terms of concepts and needs for many, many years. I have had the experience of going through everything from prospective payment in the early 80s to managed care to here we are in 2014 in the age of accountable care and population health. And I must say I've never been more excited about prospects of achieving meaningful reform. There's been a convergence of technology and tools and payment reform along with evidence-based practices that I believe have finally driven us to a tipping point. So the slide that you see before you is a Rube Goldberg device. For those of you who may not be familiar with Rube Goldberg, he was actually an engineer in the late 1890s going into early 2000 in the 20th century. And he moved from engineering to become a cartoonist. And his area of concentration was creating complicated gadgets that perform simple tasks in indirect, convoluted ways. So he knew better as an engineer, but yet he created these whimsical devices. I have shown physician practices, this diagram, this schematic, to describe what goes on inside of their practice. Most take offense, but I understand what I'm speaking about. I would also posit that this is a great schematic for how care management is done, that in essence what we're trying to do is to accomplish some very straightforward tasks, but to get us to the point of being able to deliver those very complex, simple tasks, we often create very complex processes. That is what we need to work on, and that's what I'll be addressing today. Next slide. So the need is to simplify these unnecessary complexities. I believe one way of doing that is shifting the locus of care management primarily from payers to primarily providers. Payers have had their turn driving the care management activities with the advent of patient-centered medical homes, accountable care, value-based care, and the like. Now is the time for providers to be able to embrace some of these processes, but to layer that complex process on top of an already complex process is not the simple and straightforward solution. There was a Dutch computer scientist named Edgar Dijkstra who said that simplicity is a great virtue, but it requires hard work to achieve it and education to appreciate it. And to make matters worse, complexity sells better. We know that there can be a daunting future that lies ahead of us, but I think with the return to some of the basics and to have some technology tools that heretofore had not really been widespread and scalable, I think that that's a possibility that we can truly get to. Next slide.
So, a care plan, the definition of a care plan really is something that provides for the direction of an individual's care and is a means of communicating and organizing activities amongst the care team. And so I'd ask us with that definition to take a quick step back and just ask ourselves, imagine if every patient could have a care plan. Or, imagine if we could reach out to every patient discharged from the hospital within 24 hours and identify if there is additional needs there. Or if every diabetic who hasn't been in the office in the last 12 months could automatically receive a touch point prompting them to come back in and reconnect with their provider. So with this as our high-level objective as something that would be really impactful to obtain, we look at the villain in our story here today is really scarcity. So the harsh reality is that we all live in a resource-constrained world, and there just isn't enough time of the day to touch every patient, to give every individual the personalized attention that they need to achieve meaningful behavior change. Now, this villain in our story today is not something that's unachievable, that we can't overcome. And the solution is leverage. So maximizing technology to make us more efficient, to enable us to persist and scale out the limited resources that we do have. So in the rest of our story today, Michael and I will share with you how we've taken scarcity head on, and it's in our attempt to revolutionize how care management is delivered. So, Michael, maybe you can walk through next the objectives and how you've begun to approach this within your organization, and then I'll talk a little bit more about how our products and tools have supported you in this.
Thank you, Russell. So we are talking about scarcity, and we're also talking about every dollar, every resource being spent on care coordination and care management is a dollar that is not going to direct patient care. We have to be able to, with intellectual integrity, assure ourselves, assure our providers, assure our stakeholders that that next dollar being spent on care coordination in fact yields greater return for patient impact, population health, and overall cost effectiveness using the triple aim of IHI than it would be just being spent on the front lines of direct care. So this slide is speaking to what are the three primary objectives of the work that we have in front of us. It's around prioritizing the right work to the right method. And in the old days, people, process, and technology were the three pillars of any kind of care coordination or healthcare reform. But here we substitute method for people, because to the extent that we can leverage technology and provide some of the benefit that otherwise was required of human resources, then in fact we can preserve those scarce human resources to be able to dedicate them to where the need is going to be greater. The need to focus then is to allow the data to direct our focus and to optimize the use of those care management resources. So again, they're being deployed in places where humans need to be deployed for whatever reason, due to intellectual processing or, in fact, that irreplaceable human touch. Next slide. So our work here at inHealth has been around for about 20 years. We're a physician hospital joint venture organization. We did a lot of contracting in managed care back in the mid-90s. We did Medicare coordinated care demonstration in early 2000s. We moved headlong into the accountable care space, population health. We leverage a lot of health IT and health information exchange to do that. But there are some unifying principles that have not changed at all during the course of those 21 years. I have very much respected the work of leaders such as Stephen Shortell and some of his seminal work on systemness, Jeff Goldsmith, who is a native up the road in Charlottesville, who's written a number of important thought pieces around the integrated delivery systems and what the requirements for success are. I boil these down to three areas. One is common clinical pathways. Second is shared clinical information. And a third are aligned financial incentives. The three circles in the Venn diagram on the right-hand side, engaged physician, care coordination, and health IT, those to us represent the convergence of three necessary elements of healthcare reform to achieve care coordination and improved outcomes, meeting the triple aim. 2 out of the 3 will not get the job done. All 3, we can do some wonderful work together. Next slide. So as we venture down this road, we've continued to work to have some meaningful deployment of technology to support human processes, clinical processes, and to do that in tandem with our physician and health system partners. The very first system that we deployed in our population health road was Vital Outreach. And what Outreach does, as you can see on the slide, we take hundreds of clinical protocols and get uploads daily on new activity from the practice management systems to identify gaps in care and then to automatically communicate with those patients when there is a gap in care. We've engaged over 97,000 patients with gaps in care. It might be something in the realm of prevention, so if they turn 50 and there's no scope or mammogram on file, it might be an annual wellness visit when somebody is over 65 and on Medicare. It might be a chronic disease follow-up if someone is a diabetic and it's been more than 6 months since they've had a visit with their physician. All of those represent a gap in care, and there's an ability to do a en masse, scalable outreach to those patients to engage them and to let them know that it's important for them to come into the practice to have their situation redressed, whether it's a follow-up chronic care visit or preventive visit. Okay, next slide, please. So the focus moving forward then is to take various data streams, whether it be from tracking of emissions and discharges from facilities, inpatient, outpatient, ED visits, whether it's for accountable care, whether it's for more of our vulnerable populations who may be uninsured. But all of that needs to come together in a way that actually simplifies processes and activities and tasks rather than having those multiple data streams come in and make life even more complex than it was previously for the care manager and for the physicians that they're supporting. Next slide. So what we have tried to do with all of this is to create a system which does allow for ease of use, which does respond to the needs for the care managers who have to engage both on the patient side as well as on the provider side. We took a look at a lot of tools that are present in the marketplace. We saw a lot of the work that's being done by the payers, and we just did not feel that any of those were going to be able to meet our needs as a physician support and population health organization. We have been a long-standing partner of FITEL using the tools such as Outreach and Remind, but we knew that they did not have a product that we were looking for, but they certainly understood our needs for efficiency and effectiveness and clinically proven approaches to intervention with patients and our provider partners. So we engaged them in conversation with the proposition that we create an intelligent system which really makes sense from a care manager standpoint. So it's not just a matter of designing interventions that are appropriate for any given population, whether it's CHF or diabetes or whatever, but how can we break that down into components that care managers can easily assimilate into their workday, into their calendar, into their task with tools that support those activities in an efficient way. So I will turn it back over to Russell to describe then how FITEL picked up the ball and has continued to run with the development of this system, which we're pleased to be able to have in use today. Russell.
Great. Thank you, Michael. So as Michael mentioned, he approached us a year and a half or so ago with this opportunity to really deliver a care management platform unlike any other. So as we looked at the situation, we weren't really so interested in building yet another care management tool that might be out there, a workflow tool. But as we really dug deep and looked at some of the problems that Michael was being challenged with around scarcity and scalability and trying to bring simplicity to the process, we looked at our experience with automation, data aggregation and normalization out of the practice management and medical record, our ability to normalize that data to make it meaningful and actionable. We realized that there was an opportunity to take these key assets that we have and organize them in such a way that we could optimize the care manager workflow and take an approach of using the care manager's cognitive model. And so we also recognize that this design has to support an interoperability approach. So we view care management as not as a single system solution, but as a web of connections. So our system needs to talk with medical records, which needs to talk with other medical record systems, which need to talk with other systems being used by people to manage their care, whether they be consumer or provider, clinician-focused tools. So, ultimately, as we went through this process, I'll take just a quick few minutes here to share with you some of the insights we've gained as we began building this out. One of the things we did was not only observe the care managers and the struggles and the pain points that they were going through, but we even went so far as, I put myself through the care management process so that we made sure that we designed it with the appropriate level of empathy for not only the care managers but the patients that are being care managed. So let me just share with you a couple of the layers of design that we used as we went through this process. One of the first pieces we recognized was that while a care manager might have a calendar full of appointments where they have different people that they're interacting with, we recognize that these appointments often fall through. So as we began to design the workflow and the day in the life of a care manager, we really wanted to tackle 3 or 4 key areas that care managers need to deal with to maximize the efficiency of their time. One is having a calendaring component, and what I'm referring to here is not cannibalizing the schedule of the providers and of the medical record, but having a calendaring system that is been designed to focus and be used by the care team, the care management team. And that includes not only the nurses, but the health coaches and the social workers as well. And then when those appointments fall through, as they inevitably will, being able to have quickly the ability to access either a to-do list of things that need to be done, interventions, so specific targeted things that need to be done to help accomplish care plan items, a general work list, and then recommendations that the system might provide to help direct things that need to be done. The other pieces we looked at was the need to allow a care manager to quickly navigate through the guideposts of a program. And here's where we really see two conflicting forces being applied to care management. On one side, you have the force of personalized care and that personalization that's required to achieve behavior change. Now, on the other side of the fence, you've got the need for standardization so that you can report and show value. So one of the things as we did this, we built out a architecture that allows us to balance both of these worlds. And while I can't give you kind of all the details now on this webinar, you can simply look at it on this screen. So we have within the plan several different modules. Those modules then consist of actions, and those actions consist of steps that guide the care manager through the process. And the beautiful thing about this is those steps are designed to change as the conversation changes. So as I'm on the phone and interacting with an individual, and I set answers to those questions, that changes the pathway which I'll take, which makes it very easy to quickly document yet stay engaged with the individual. And then ultimately, on the back end, it allows us to then go back and report and show the value and the number of interventions and the things that were provided to each individual as we navigate through the care management process. And ultimately, those assessments drive to the creation of a comprehensive care plan. And so we've broken this care plan, again, up into several different areas. It's been designed with a fundamental architecture around some of the latest theory and behavior change. It allows for a personalization. So, for example, you see on Prove HDL, the task for the individual is very personalized. So eating wheat checks for breakfast, right? Yeah, and we can also look at the barriers that are preventing them from improving that HDL and the interventions that the care manager is providing. Now, again, here's where the automation and the technology can scale. It's very difficult to know that when I'm going into the call with Jacqueline today, that to improve her HDL, she needs to eat wheat checks, in the mornings. But once that's said, we can now leverage our experience in automation and persistence and follow up with Jacqueline using some of the automation and the technology components. This also is designed in a plain language to aid in cross-team collaboration with non-clinical team members, for example, like a social worker or maybe even a health coach. And it's designed for system interoperability using some of the CCD structures and standards. So there are many more aspects, but all of these add to successive layers of design that allow care managers to effectively use their time and to really achieve meaningful behavior change with those individuals that they are able to engage with, and then allowing the system to engage with those to achieve the scalability that's needed.
So this is Michael, and I hope you can appreciate just from those screenshots both how straightforward it is to the care managers, as well as perhaps the underlying complexity of decision support underneath that. So whether it be around the transitions of care program, or whether we're talking about a healthy coaching program, healthy weight program, or something along the comorbid chronic disease that Russell spoke to, there is a lot of effort, as our Dutch computer scientist said, to turn that back around into simplicity. And I hope you also noted, Russell, he does live his work. He was a client in our care management program, and if ever there was a motivated systems designer, it was Russell, because we know all of his bad health habits now, and he was very motivated to keep our care manager off his back. So he did live it, and he understood what his care manager needed, and they have done a great job of delivering that. So as we look to the future, success does beget success. You know, even though there's ample evidence about the impact of chronic care management, care coordination, transitions of care, and so forth. We still have resistance in the system in our market around the widespread deployment of interventions around that. So if we go to the next slide, I'm going to give a few snapshots of some programs where we've used the various tools in our toolbox to achieve some positive change. One of those is a very strong partnership with Bon Secours Virginia Health System, where we have engaged very deeply with their employee health group and their provider group on improving the health and well-being of their employees. They have been widely recognized as a favorable place to work, and we think that this is the type of program that contributes to that. So as you can see, some overall summary statistics. We did increase the, working with Bon Secours, of course, is increased the employee utilization of primary care. The ED visits went down. The number of high-risk employees decreased. The number of risk factors decreased. The number of the percent reduction in risk factors went down. And those enrollment rates for all of the programs were much higher than industry averages. In diabetes, everything was in the right direction, whether it was A1C or BMI, same thing for hypertension. Next slide. With the work on healthy weight, which is a program, again, in the Engage Vital Care Management program that we just spoke to, you can see a consistent decline across weight and across the BMI for the percent change, and the greater the BMI, the greater the change that occurred in the healthy weight program. We're very pleased with the participation around all of that and the outcomes around all of that. Next slide. And it's also nice to see that we can engage with the employees in this case in a way that they felt so positively about. This projects well in terms of sustainability of the outcomes and results, whether it is around the health being improved through participation in the program, the quality of the information that was provided, or the recommendations that the Good Health Care Management program be available to their friends. Next slide. One piece of data that I referenced in my opening remarks, this is more detail around the outreach results, and this is working with the Bon Secours Medical Group. We have booked a lot of patients who have a lot of needs. The ROI on these bookings is running anywhere from 6 to 9x, and with a substantial reduction in the gap of care. We can trend this at an individual level. We can also trend it across patient populations. The average number of days related to the gap in care has come down significantly. We've also been able to target this to Medicare patients in support of the Medicare Shared Savings Program of Bon Secours. Next slide. So a long way to go. I often like to quote Churchill. And one of my favorite quotes with Churchill is, "This is not the end, it's not the beginning of the end, but perhaps, God willing, it might be the end of the beginning." So let's go to the next slide. And we look at the journey from fee-for-service to value-based care, and I know we have a lot of markets represented around the country on the call today, and I can appreciate every single market is somewhere else, somewhere different on the continuum on that journey from fee-for-service to value-based care. As you can see from that graphic, it might be a journey that's shrouded in fog, but we know where we need to head. And I would also like to say, some people have talked about the parable of the person with a foot in two canoes, and the implication that eventually you'll have to choose one canoe or the other, or else you'll fall in the river. However, I think that we're going to be having feet in two canoes for a long, long time, and I can't emphasize enough that to have to do a rip and replace as we transition from a fee-for-service environment to a value-based care and population health environment, if we have to do a rip and replace, we're not building the foundation upon which we can grow programs in the future. I've called the types of programs I'm referring to as straddling strategies, that they work effectively in the old or current world of fee-for-service just as well as they do in the value-based care. So it does allow us to gain from experience in that foundation moving forward. Next slide. In the spirit of the World Series, we have a bit of a metaphor here with the baseball field, and go Royals. We're all looking forward to the game tonight. And this is our model for a comorbid heart failure example. This was developed by our Chief Medical Officer, Dr. Steve Cavallari, working with the MD Value Care Quality Committee. MD Value Care is an ACO that we support here in Richmond. And you can see what the care compact that was developed involves. It has to do with defined roles and responsibilities, mutual standards of care, and a shared value proposition, principally between the primary care and the cardiologist, but also, of course, involving the patient as well. We have implemented the Coleman model from Eric Coleman, University of Colorado. We have nurses dedicated to the effective transition of patients from the inpatient facility to their home. So we very much believe in this team approach, and it's, again, nice to have a tool that allows all of these various parties to work together seamlessly. Next slide. I'm going to spend a few of my minutes now over the next 5 or 6 minutes talking about a specific case example of an ACO. The ACO is based here in Richmond. It's called MD Value Care, and this is a collaboration of 20 different physician practices, about 400 physicians. 45 of those are primary care physicians with leading specialty groups as well. They have 137 facilities across Virginia. Next slide. They approached inHealth about 1.5 years ago to see if we could apply some of our management, network development, and care coordination and systems tools to help them further their goals of wanting to do the appropriate thing and improving outcomes at lower cost with improved patient experience, but to do that from the position of independent physician practices, collaborating one with another. And so we embarked on a management support structure that had to do with governance and systems and care management and reporting. The first things we did was to map out their overall strategic objectives. And shortly after we finished that, next slide, there was another offering for participation in the Medicare Shared Savings Program. On their behalf, we made application to CMS, and then this past October, we were awarded a contract. As it turned out, we have our initial population was 12,300 beneficiaries. We're the class of 14 with this. We focused the attribution on the 5 primary care groups, but the care processes are aligned with the specialty care groups, and those include cardiology, pulmonology, orthopedics, and so forth. There are over $300 million in projected expenditures, and we have spent much of the past year working on the systems and processes to achieve the outcomes that will be necessary for success. Next slide. There's an intense effort, of course, with the ACO 33 reporting. Any of you who are involved in that, I share your pain. It is an extensive, deep effort. We do intend to leverage Vitel tools. We are deeply engaged with practices themselves. They have done heroic work in transforming some of their intake processes, their rooming practices, the way they capture and code inside their electronic medical record. So we are certainly looking forward to some success on that front. But we also want to leverage that for potential commercial contracting and possibly serving as a reporting service bureau for these folks moving forward. Next slide. So as we look forward as an organization, we know that there's still a long way to go, and I think anyone in this space can appreciate there's always more to be done. We need to do more on the consumer-facing front. we very much appreciate the engagement of the practices with the patients. Part of our core mission is to restore the sanctity of the physician-patient relationship. Hopefully, some of the work that we're doing is enabling the physician to do what he or she does best, and that's to be able to engage and lead to successful interventions on behalf of the patient. We certainly want to continue with the practice workflow integration. If the work that we're doing as an ACO is viewed as separate and apart from the workflow inside the practice itself, we have failed. I'm very encouraged with our work in that regard, but there's more to go. The home-based devices, bring your own device, the personal work, mobile health, and all of that. We know that there's a brave new world out there. Some markets are much further along than this one is. We think that that's an effective way of communicating back to the healthcare providers and support services in between the office visits, but we need to have more refined mechanisms for who monitors those monitors, and we can streamline a lot of that work. End-of-life support is certainly very present, I think in ACOs, but more generally in our society. I think we've not gotten that right as an industry, and there's more work to be done there. I just saw a graphic this morning on how much has been spent on the last 15 years of life in this country versus in other advanced countries. So we know that there's more work to be done there. And to leverage all of this for the creation of healthy communities. So if I may offer up one more Winston Churchill quote, it says that history will be kind to me, for I intend to write it. For all of you on the phone, I think we all have the opportunity to write history right now, to make history. I think we've never been in a position where so much fundamental change is upon us, but not necessarily in an overwhelming way. I think that we have the tools, we have the data, we have the partnerships and relationships, and we have the payer-aligned incentives where we can have some meaningful efficiency moving forward. I'm grateful to be on the journey with all of you, and I look forward to your questions, and hopefully we'll have an answer or two for you.
Great. Thank you, Michael. And I think the biggest question that I've seen come across the poll here is about the Giants and the Royals. So we'll probably table those for a separate webinar. But no, great.
Being on the East Coast, I have no skin in this game, so that's why I can be a free agent.
Very good. Well, thank you, everyone, for attending the webinar. Again, to ask questions, you can use the question functionality within the GoToWebinar control panel. And we've got a number of questions here that we'll begin getting through. We will make the slides and recording of the presentation available. So a number of questions about that. Michael, one of the questions that came across was really around whether this was, inpatient versus outpatient, and I think I'd maybe add to that, and I know you touched on it a little bit, but maybe underscore a little bit more how this system is being used, both inpatient, outpatient, and employer-based, your approach there.
That's a great question. We know that the largest single source of cost in any kind of ACO is going to be on the facility side, inpatient, ED, and outpatient. So we have done a lot in the transitions of care space, both getting the frequent flyers hooked up with primary care physicians, intervening with the uninsured if they have no other source of care, but also ambulatory sensitive conditions, being able to note that. So we are moving to automate those processes more fully using yet another FITEL tool called Transition. And so what Transition does is there's an outbound call to the patient's home to make sure that they have made it home, that their pain today is no greater than yesterday, that they've gotten their PCP follow-up appointment, that they've gotten their medications filled, that they don't have any questions about their their discharge instructions. And then based on those, some 20 or 30% may need to have a human intervention. So again, this is the shotgun and laser beam approach, where we want to make sure everybody gets hit with some support coming out of the hospital, but then we focus our scarce human resources on areas of greatest need. We supplement that with work from our health information exchange. Some of you may participate in something called ADT alerts, encounter alerts, clinical alerts. Various names are applied. But we have the patients enrolled in our MSSP ACO population registered with our HIE, and whenever there's an inpatient admission, inpatient discharge, or ED discharge, then there's an alert that is sent both to our care management group at inHealth as well as to the practice themselves, so that they can do the transition of care follow-up. And if they meet certain criteria, our care managers then know to launch the Coleman transitions of care model, make their way to the patient's home, do the in-home assessment, and make sure that they are attended to and don't fall through the cracks in that critical first week at home. So there's an intense front end to all of that, but then at that point we're making sure that the patient does have the support systems in the community itself. So it's really that data trigger on the back end of the hospital stay that enables all of that to be launched.
Great. Michael, one quick follow-up to that, so what you were just referring to, and then we'll move to another question. Was that alert that you mentioned based on an HL7 feed?
It is. It is an HL7 feed, and so when the HL7 ADT alert comes in, we check against the roster of patients for that alert, and where there's a match there, that then the alert then proceeds to be communicated either to or both to the practice and to our care management group.
Okay, great. Now, another question just came in was around, I guess, more of the people process angle. And the question was related to, was there resistance from your team to use yet another IT system, and how you got adoption on that front?
That's a wonderful question. If this were just another system, I think that there would have been great resistance. I think that what this is doing is replacing everything from Post-it notes on the cubes to Excel spreadsheets and Access databases and some homegrown systems and some old legacy systems that were in place. So yeah, if this were just another, I think I would not make a pass through the care management department very often. But we do see now that this system is in the process of taking over all of those various pieces and parts so that we have one unified approach.
Great. And we can definitely tell that just from our side, as we look at the use and utilization information. I think one of the key difference in the design points was the thought process and the workflow of the care manager was heavily considered, and it influenced the design of the product to help ease the use and make it more efficient for them. So they were definitely highly involved in how the system worked. Another question related to scale, and Michael, what I'll do is I'll take the first part of this question, and I'll ask you to respond from your perspective. The question was related to how we, along the efficiency lines, how do we envision engaging with existing systems, and specifically around public health and other tools out there that are kind of doing things in this vein. On my side, I'll talk about, so from a systems design, we built, as I mentioned earlier, we built the care management as not a single point system. Meaning, when we constructed the system, we knew that we were going to have a number of part components that we could offer that were really valuable from things that we have done, particularly around automation, data aggregation. But we built it in a component-driven system, meaning we recognized that there were components that we wouldn't have and that we would need to interface with, both exchanging data and allowing the care managers to, via any number of mechanisms, access other data, other content, other systems, and provide a web. Our ultimate vision is it's a web of connections where some of those connections are stronger than others, but there is the capability to leverage other strengths across other systems. A simple example might be a scale that is Wi-Fi connected, could influence the assessment or feedback information to a care manager where they might not need to have as often a follow-up from a human perspective, or where that might not be using it could trigger an alert or a workflow item for the care manager to follow up more frequently based on, again, data that's being collected from other systems. Michael, do you want to address a little bit on the public health side or other community resources?
Yes, I'll add on to those comments, Russell. One is just a cautionary note that we need to make sure that we don't have a healthcare industry where patients have been, where their care has been under-coordinated to now move to a place where they're over-coordinated. It's almost as bad as not having any coordination at all. And there is opportunity for the managed care organizations to be intervening, the retail establishments, the pharmacies, the primary care, the discharge planners, some of the consumer apps that are out there. It can be confusing at best to the patient, perhaps danger and patient safety issues along the way. So I'd say a lot of the work of an effective care manager is actually helping the patient make sure that they have a streamlined foundational set of information that's actionable, it's comprehensible, it's understandable, and allows them to move forward. So I'm glad when there are community resources and there are public health resources available, but we just have to make sure that those are properly accounted for and create value and not detriment to the patient.
Great. Thank you, Michael. Another question deals, I guess, building a little bit on the adoption front in terms of timelines to implement the system. So, we mentioned several different of the FITEL solutions in place and other systems you have. So there's probably not one answer, but maybe you can address broadly some of the timelines to implement and deploy some of these solutions.
Yeah, and candidly on the engaged care management tool that we've talked about, we wouldn't be a fair model for that because we have been so involved in the co-creation of that with you and your team, Russell. So I'll punt that one back to you. But I'll say that it's been straightforward on all of the other tools. We have implemented the FITEL outreach at each of the 5 primary care practices. We began that work over the summer, and I think we're live at most of the practices now. So, we had some additional complexity that went into that because of how we were working on the ACO population at the time. But generally, I think a couple of months has been our experience. We look forward to the rollout of the transition product to support the discharges going home. I will say if any of you have HIEs working in your neighborhood, that sometimes some of the interfaces that are already in place with either the health systems or the practices can be leveraged, and if not the interfaces directly themselves, at least the skill set that can be supportive. One of the, I'll also give a plug back to your implementation team, Russell. They recognize that most physician practices don't have an extensive IT shop, and so there's not an expectation that this be a heavy lift on the side of the practice for implementation.
Great. Yeah, thank you, Michael. And just to add a little bit to, I guess, some of the thought process or vision around that is, each of these modules that we offer accomplishes, a particular task, whether it be reconnecting patients that are, not coming in and need to come in, or whether it be facilitating a care management workflow and a care management program. And each of them have different timelines associated to them, but the intent is to provide value. And so we do a lot of pieces, not only through the implementation process to make sure that we're not just throwing a tool at a problem, but we're really collaborating and partnering with our customers to solve their problems. And as we do so, everyone benefits. Next question we'll get to is, and again, Michael, I'll take the kind of the systems design view of this, and if you want to add anything on, that would be great. The question was, how do the various disciplines, collaborate within the care management system? So whether it be the hospital, transition coaches, outpatient care managers, practice-based, providers and care teams. So from our perspective, when we went in and designed the care management module, we looked at the whole system and how all the pieces could work together. And so there's a number of things, obviously, we can show you on a demo, but whether it be the ability to assign tasks. So, for example, we have a care manager that might do the bulk of a care management program. But there might be a module around diet education or, counseling or coaching that might be better handled by another staff on the care team. And so we have the ability within the system to then to assign out, whether it be referral management tasks or whether it be specific, hey, this person needs coaching on diet and exercise, and so we're going to give that to a dietitian rather than the generalist care manager. And so the system supports that and then supports tracking various to-dos and other things. So if I create a to-do and assign it to another user, I can track whether that's being closed at my level, or I can go into the individual patient level and see an aggregate of all their different tasks being assigned out to different users. It is a web-based application, so from an accessibility perspective, it can be accessed from almost anywhere. Michael, do you have anything to add to that, or we can move on to the next question?
Oh, just quickly, more on the principle than anything specific, and that we have two principles around that. One is that any of the members of the care team should be practicing at the highest level of their licensure and capabilities. And the other is we've often described ourselves as multilingual, that we have to be able to converse with everybody in that care continuum, from long-term care, home care, acute care, physicians, labs, pharmacy specialists, primary care, and so forth. So to the extent we can be multilingual, I think that gives us the ability to synthesize a lot of the various pieces and parts into something that's greater than just the sum of each of those.
Great. Michael, earlier in the presentation, we were talking about the your MD Value Care ACO. You mentioned you had a bullet point on the slide about the reporting boot camp. A couple of individuals on the webinar today would like you to delve a little bit more about what you mean by reporting boot camp.
Okay. Well, this is where we had a couple of folks from the FITEL shop come in who had a lot of experience with ACO 33, and we spent a couple of days together looking at each of the measures and what it would take to capture them, what they meant, all the exceptions that go along with that. And so what we wanted to have happen with that is our ability to then go out, and we have a couple of executives who are trained to do just this, go out to the physician practices and engage them in the same kind of process, ending up with a clinical documentation guide for each practice, for each measure, what the current state is, whether there's a gap, and then an action plan for how to redress that gap. So the boot camp's part of it, but the boot camp, just to let us get all concerned about all the things that need to be done without an action plan, wouldn't have been very helpful. But the action plan that went along with it, I think, has been extraordinarily helpful. We've continued to educate ourselves. We've talked to a lot of our colleagues. The Premier Collaborative for Accountable Care has certainly, for those of you who are involved in that, they produced a lot of good work and support tools as well. So there are some support systems out there, but we like the process that we did with FITEL, and then we picked up some on our own as well.
Great. Thanks. The other couple of questions around, and I'm just going to aggregate some of these. If there's additional details, we can follow up with the individuals one-on-one. There's a number of questions around interoperability with other systems, so Epics and Allscripts and some of the other medical records out there, and how it's intended to not be another system, another thing that somebody's got to go do. And so I'll talk the systems design approach, and then Michael, you can add some color to that. So from our perspective, we've designed the system to interoperate. We have feeds that go into Epic on a number of different areas, whether it be touch points and automated call events, again, supporting things like meaningful use too. We also have designed the ability to export the data in a CCD format, so that the data that is captured directly in the system can be output in a a standard way to interface to other systems. So we have a number of varieties and customers that have different levels of integration based on what they're doing and what products they've purchased. Michael, do you want to maybe take that maybe from a care management approach and how you're working with, as you work with the different organizations, and how you're interfacing back to the medical record, and I guess maybe the point of care with the workflow of a provider?
Yeah, there's a couple of aspects to this. On the various specific functions, programs and products that we use with Vital, like Outreach and like Transition, those are straightforward feeds out of an Epic system or Allscripts or eClinicalWorks, whatever the EMR system might be. So that much has not been any particular challenge, easy for me to say because I'm not the one responsible for building the interfaces and feeds, but that's a very straightforward process. I think what is more work for us to do as we move into 2015 is starting to integrate across systems. By that I mean we use Verisk and their provider intelligence tools for the claims analytics, for risk stratification and predictive modeling. So we have the EMR on the one hand, we have the Vital tools around population health and patient engagement on another hand, and if I had a third hand, then we've got the claims analytics. What we need to now start doing in 2015 is cutting across those so that those aren't independent activities, and I'll give you one specific example that we'll move toward in 2015, and that is where we have the Verisk system, we know who's at highest risk for ED visit, readmission, admission, polypharmacy, high cost. Those will be 5 flags. We will actually bring those flags over from the ACO population into the Vital Population Health and Analytics Suite so that we can identify not just the patient who has an A1C over 9 and the BMI over 40 who's been 6 months without seeing their physician, but also who is at high risk for high cost and ED admission. So, yeah, I feel good about where we've come with the interoperability, recognizing, again, there's more down the road.
Great. Thank you, Michael, and thanks, everybody, for your attendance today. There's many questions that we weren't actually able to get to, so I want to leave you as we try to be respectful of everybody's time and end the webinar on schedule. We want to make sure we leave you with the contact information, or you can reach out to us directly or through our organizations, inHealth or Vital, and we'd be more than happy to continue to follow up. And Renee, do you want to maybe give a plug for the next webinar?
Absolutely. Thank you. Our next webinar will begin on November 19th from 12:30 to 1:30 p.m. Eastern Time. It is on population health, creating a culture of wellness, and Dr. David Nash will be joining us. He's the Dean from Jefferson School of Population Health. This concludes our webinar. Thank you both to Michael and Russell. Extremely important and very informative webinar, and thanks for all of the great questions that you all asked. At this time, the webinar has now ended. Have a great day. Thank you, everyone.